before? Or some of you who haven't?
Not with the anesthesia department.
Okay.
Okay, so the way this one's a little different, and we'll probably both sit down, is that we want it just to be a discussion, and we're going to guide it so that we accomplish a few things and get a chance to have some give and take on the article. So the learning objectives for this, what we try to do, and Nate, please jump in because he's much more eloquent than I am. What we are trying to do is move through during the year and then repeat next year. So if you're off somewhere, maybe you'll catch the other types. We'll try to hit a different kind of article every month so that as we move through a year, maybe a year and a half, we try to cover kind of the different types of articles you might see and how you might want to interpret them. So today what we're going to try to do is learn to critically evaluate manuscript of a prospective clinical trial involving a drug effect. So we haven't really done that yet. So we're going to understand, and this one involves pharmacokinetic, pharmacodynamic modeling. So we're going to talk a little bit about what those things are and how they might be used in a study, and then take it a step beyond pharmacokinetic, pharmacodynamic modeling, because if you've read the article, you see these guys are doing population PK/PD, which is nonlinear mixed effects modeling combined with pharmacokinetic, pharmacodynamic modeling. So it gets a little more complicated, but we can, it has an advantage, and we'll get to that, is that by using this technique of population PK/PD, you can actually, within the modeling, test a hypothesis. So in a way, it's very convenient. So it's a lot of work, but it allows hypothesis testing kind of as you go, and you can also ask you can test several hypotheses if you want. And we're going to talk about the advantages and disadvantages of doing a PK/PD study in the clinical setting and in conducting drug studies with both PK and PD data when they're used. So what are the advantages? What are the disadvantages? Okay, anything you wanted to add to that?
So the things to think about with this are what are the comparisons? So if you're going to do a clinical trial, you need to know who you're comparing, what you're comparing, and you need to have that really clearly defined so you know what you're actually testing and know how to make a decision based on that information. And I think you got into some of the analysis and how you do that. And the other part is the setting, like how do you actually study this? So the two parts that he talked about were either in a clinical setting, which means your goal is not to do research. It's that you are doing research while you're taking care of patients. So there's some trade-offs that go with that versus you bring in participants explicitly for the research, which means you control whatever components that you want to. So that's an important distinction to make, and part of, I think, what will help you understand what's going on with this study and what are the trade-offs, and as we look at the benefits.
Okay. So
we got introduction.
I think we're missing several people.
Yeah, probably. Does anyone see?
No, I didn't think so.
Going on introduction. Okay, so.
All right. So we're going to wing the introduction and assume that everybody read it. And I have, I kind of broke down a couple of questions. I like the intro to be kind of, so here's the article we're going to talk about. We'll eventually talk about what they mean by non-steady state, modeling of ventilatory depression, depressant effect in remifentanil in awake patients experiencing moderate to severe obstructive sleep apnea. So in the introduction, first thing that they should make clear or you should think about is what's the clinical issue. This is a clinical journal. What's the clinical issue here? You might want to, it's pretty straightforward.
Seems like they raise kind of like anecdotally that, opioids have patients with OSA are more sensitive to opioid
Well, even
respiratory
before
suppression.
that, okay, that's okay. What's the clinical issue? So is obstructive sleep apnea present any problems in the perioperative period?
Yeah, that those patients were at twofold high risk for
Exactly.
respiratory issues.
And if you could look at, they cite 4 studies at the very beginning saying, hey, and one of them was registry of all of Canada. And that was done by Frances Chung, who's a pretty well-known anesthesiologist, and she led those studies. And then if you look at the next 3, they're also all by Chung. And so she's a major player in saying that there's respiratory consequences to doing anesthesia and surgery in patients with sleep apnea, right?
So that's your problem.
That's your problem. So now it's your turn. Because you had that one nailed.
They're saying that, like, anecdotally, people had thought that patients with OSA were more central to respiratory, or more susceptible to respiratory suppression from opioids than non-OSA.
Well, there's different kinds of sleep apnea, right? So there's lots of elements that contribute to this respiratory compromise afterwards. There's obesity, there's sensitivity to maybe drugs. And if you look at the literature for, and this will be interesting because most anesthesia ones don't segregate. Most sleep neurologists will study the exact kind of sleep apnea that each person has, and there are many elements to this issue. So now it's your turn again. Say what you said. So the one element, so it might be anesthetics, it might be surgery, it could be hypnotics, it could be inhalation anesthesia, it could be residual muscle relaxant, it could be all kinds of things, but they are interested in studying which element?
The opioid effect.
The opioid effect. And specifically, which part of it? It's not just opioid as it contributes to obstruction, or opioid as it contributes to what exactly?
It seemed like they were trying to get like the central suppression of respiratory drive.
Respiratory drive. So the kind of the thing that is out there anecdotally, a little bit anecdotally, but makes sense is perhaps these people are more sensitive to opiates than normals or controls, which would reflect in their respiratory drive. So that gets us to where I always like to go. The most valuable part of the introduction is the hypothesis. So now we've identified the problem. We're trying to get, okay, what are all the things that might contribute? Which one area are they most interested in? And then what is their hypothesis? You can read it verbatim since nobody's here who, it's the last sentence, usually the last sentence.
That people with OSA will be more sensitive to respiratory.
More sensitive. How do you measure sensitivity? How do you know if they're more sensitive?
More events of respiratory.
Events, that's one way. That would be more of an outcome study where you're looking backwards. This is a prospective clinical trial of 2 groups, and you want to measure. So we're going to look at, you don't have to answer it now. That's the purpose of the journal club. Yeah. But it should say, okay, how do pharmacologists look at sensitivity of people? And how would you prove it or disprove it? So that's where we're going to go. It's the sensitivity piece.
And just one piece on that. It's really important to have a testable hypothesis so that you know what question you're asking and how to answer it so that you know whether to reject it or accept it. right? Because like you said, it's in the last sentence of the introduction. Here's what we think is going to happen, and here's how we know how to answer that question. If you don't have those two pieces, the whole thing falls apart. So if you can make it as specific as possible, and it has to be testable. That's a key point of any study. Anytime you pick up a paper, if there's not a hypothesis, it's very hard to tell whether they've accomplished anything or not. So that's just to make it a little more general as well. That's a specific part for this paper, but for all papers, you want to find out what are they trying to do and how do they do it, and what are the metrics to know whether to accept that, okay, we were right, or maybe we're wrong, or we don't have enough information. Those are sort of the three outcomes of any study with hypothesis testing.
Okay. Anybody?
Yep. Tom, you're on methods. Who else is on methods team? Team methods.
I got it, yeah. So I see you have a nice outline up there.
Yeah.
So I'll try
It gets
to...
worse. It gets worse because the methods.
I went line by line.
These are the heaviest methods I think you're going to ever encounter.
Yeah,
so,
it's pretty bad.
But I'm gonna help. So you don't have to worry.
All right. So what do you do though when you wade into a method section that seems absolutely ridiculous and way outside your expertise?
I just went line by line and made little numbers, and I don't know. Just I like put a question mark here where I didn't understand something. So
Okay. And that's good. Start with what you know,
Yeah.
right? If you and then look
Yeah.
and see what you need to look up, and which pieces are essential to understand what they did.
Gotcha. Yeah, so for subjects, it says they started with 50 patients between 18 and 70 years old. They were scheduled to have head and neck surgery. 30 of those patients.
We're going to be practical. I'm going to jump in with practical.
Yeah.
Why head and neck?
I'm guessing because they might have more OSA.
They're going to be operating on some of these people for OSA, and if they're going to inconvenience surgeons, it ought to be all the same surgeons, and they ought to be interested in the question.
Yeah.
If you tried to do this in the ortho patients,
Be like, what's OSA?
Medicine consult.
so that makes sense. I just like to throw those in because, like, if you're going to make a study, you want to, how do you recruit? So that makes it easier to recruit.
Well, and you're enriching as well. That's another part we've talked about. If you've got something that's not common, you're not doing a population-based study. You're doing an enriched population so that you can recruit more people more effectively, faster. That sort of
Okay.
thing.
So then they divided them.
Mm-hmm.
So these are all ENT patients.
Yeah, so 30 had moderate to severe OSA. And then they don't elaborate more on that right there. They say that they're scheduled for ENT surgery for their OSA, having failed, having refused, or wishing to discontinue CPAP treatment. That AHI for them was 15 or more episodes per hour. And they also had 20 patients without OSA. That was using a stop bang like survey that they did with them.
Everybody know stop bang? Good. Okay. Good.
It's like the one we do for adults, right?
Right.
So that's like snoring, tiredness, observed apnea, blood pressure, BMI, etc. That was the control group. So 20 people without OSA with the stop bang survey. They excluded patients who were either morbidly obese, had severe neurologic, cardiopulmonary, or psychiatric disease, as well as those with chronic pain treated with opioids.
Why? I mean, I had to ask myself that.
Yeah.
Why would you throw out obesity?
Yeah, I put a question mark. So I'm guessing like if we're trying to control for things like obesity or for people on chronic opioids, we would remove those patients from both groups. So
Right. Because your first group might not have as many obese people as the OSA group.
But you're studying something different. There's
And
different
something
types
else.
of sleep apnea, right? So maybe this is just an anatomical. I don't know who's left after
Well,
that.
it'd be
Who has
central.
sleep? It's
I
central.
have central sleep apnea. I use CPAP, and my polysomnography was over 40.
So central.
So And I'm not a candidate for any of these surgeries because CPAP works great. So that's just to let you know, there are people who have sleep apnea who aren't anatomically a problem. But so the question, am I more sensitive to opiates? You could have just asked me and not done this silly study. But yeah. So, but they elaborate pretty carefully about how you get in the control group and how you get in the study group, and they have some patients that have a little bit of snoring, but it's not too severe, and we'll get into that a little bit. What we already talked about, the important inclusions and exclusions.
So that's who, right? So then next section is the what, right? The study design.
What are they doing to these people?
Yeah. So they didn't. So this was like you said. There's like clinical versus, I guess, non-clinical. So this is in the clinical OR where people are doing patient care. These patients did not receive pre-medication. It was in the OR before induction for general anesthesia. So they placed the ASA standard monitors. They breathed some oxygen-enriched air, 50% FiO2 throughout the experiment. 3 minutes of stable breathing with no drug exposure. They received 10-minute remifentanil infusion at 0.2 micrograms per kilogram of ideal body weight per minute. That was through an AC IV that they had using a syringe pump. They elaborate that the infusion rate was selected to reach a remifentanil effect site concentration of approximately 4 nanograms per milliliter, although they did not measure that. Which,
But you wouldn't. But beforehand, you have to know how long you want to infuse, and what your infusion rate ought to be to get you to a level that ought to get you some respiratory depression. So they did that. That was their homework before the study.
Got it. To figure out like what
Yeah.
amount they want to give and how
Yeah.
long. Okay.
Yeah. So,
Yeah.
was it in this section where they talk about the mask and the?
So you get a good seal.
Or is that in the
Yeah,
next part?
I-
That's in measurements, right?
Yeah, I didn't talk about
Okay.
it. It's up there. It said,
Okay.
so they're connected to an anesthetic circuit, a tightly but comfortable fitting anesthesia pillow mask, breathe oxygen enriched air, 50% FiO2.
So how could that have gotten messed up? So they made a decision here, right? They wanted to get to 4 nanograms. But let's say they doubled the concentration, changed the time. I mean, they could all go apneic and then your study is done, or that's dangerous, or it's too low and you don't know what's going on. So it's a pretty important decision for the validity of the study to make sure you're studying what you think you are.
Okay. And the mask was tight fitting enough so that they could measure minute ventilation with a mask. So, I mean, with a tube, that's pretty easy, but so they had to be real cognizant that this was there was no leaks. The leak would throw this all off, right?
Yeah, because I know clinically, like, it's hard to get that seal to work for me. I mean, so be really tight.
Right.
That's all I.
Okay. And then they're measuring entitle as well, and rate. Is that correct? I think
It's
respiratory
under
rate.
next section is measurements. What they got. So
Yeah, I was jumping. I don't have it in front of me, unfortunately.
Cool.
Should.
Yeah, so for measurements, so this was at Stanford. They did an Epworth sleepiness scale. They recorded demographics. So they had polysomnography parameters related to breathing. So that's like number of apneas or hypopneas. They measured peripheral oxygenation, number of desaturation episodes by at least 3%. They also measured data on sleep efficiency. They asked the participants about their use of CPAP at home, what kind, et cetera. Before and during the remifentanil infusion, like you mentioned, they measured ventilatory parameters of interest, including minute ventilation, expired tidal volume, ventilatory rate, partial pressure, and tidal CO2. And like you said, those are measured through the tight-fitting mask. That
But comfortable.
Okay. So the data was captured from the anesthesia machine with a video camera on the, so I guess they took a video camera and looked at the anesthesia machine screen just to document it. That was at.
Is that the sophisticated way to do it or the poor man's way to do it?
Poor man's way to do it, yeah.
Okay.
Absolutely, yeah.
How else could you do it?
Other than writing it down, I mean.
Well, no, that's the poorest man.
I mean, you could have it directly transferred to some electronic record, yeah.
Yes, yes. So that'd be another way, and then another one would be, and they allude to it, is don't use the anesthesia machine. Bring in some calibrated equipment. This is just as set up by the anesthesia techs that day.
So there's some margin for error there.
Could be, but they did some tests against a real machine and said, well, it wasn't significant. So.
So they also measured alertness of the study participants. That was at the beginning of the experiment and also at the end of the infusion. They used an 11-point verbal numerical rating scale, where 0 was wide awake, 10 was cannot keep their eyes open. They also did a 5-point responsiveness component of the observer's assessment of the alertness sedation score. So 5 would be responds to their name readily, and 1 is does not respond.
What's 4?
4 is lethargic response to name spoken. Yeah.
It still could do it.
Yeah.
Okay.
Yep. So going on to data analysis, that's still in the So
So you can talk about the first paragraph. I'll let you do that one.
Cool. So they presented the individual, so they had demographic and they had morphometric parameters. Those are presented as both for the number of patients, means plus or minus standard deviations or medians. They used Friedman's super smoother, which they're saying, so, I've never heard of that before, but I'm guessing, so they're saying that they used our language. I've heard of that before. That's one of the statistical softwares that we use.
And graphical.
And graphical too.
Yeah, so you can look at your data and you can run this smoother through it.
Okay.
And it was an interesting thing that they did. What did they use that for? I'm reading that, what are they?
Yeah, so they use that to compute the typical time course of all the collected ventilatory variables in each individual patient. And so that facilitated the visual exploration of measures of both a ventilatory response.
Right.
Yeah.
And they picked the one that looked the nicest.
Yes. Yes, they mentioned that a few times.
That was the evaluation. They picked the one, and actually your eye is pretty good for this kind of stuff. Yeah. But the smoother helps, and it gives you a way to look at it so that it's not as noisy. But the respiratory rate, as you can imagine, some of these other measures were too noisy for them, so they dropped them. Okay, and so the carbon dioxide was too noisy to measure, right, or to analyze, and we'll get back to that because they have a cheat. I mean, a calculation. So let's go to methods, and this gets so the next few pages are some really dense PK. And who do you think's doing all of this? Is there an author?
Biostatisticians? I don't
know. No, there's an anesthesiologist who basically invented all this stuff and did all these studies. He's not the first author on any of it. It's Steve Schaefer. I don't know if any of you know Steve.
Heard of that.
He's kind of a polymath. Really, I mean, he knows about just about anything you could ever think of, including math. But the but the pharmacologic, the reason why there's a pharmacological model, and why is getting back to what you said in the hypothesis is the sensitivity. We're going to drill down to a parameter that measures sensitivity in each individual. So each individual is going to have a sensitivity score. So that's where we're going. And then each group will have a sensitivity score.
Yeah.
And then we can apply another parameter to see if there's we're going to compare the groups.
Gotcha.
Okay. So, so anyway, so that's kind of why there's a pharmacologic model and why we have to go through so much pain to get to fully understand what they're doing. So this is kind of the basic model that they're using. It's that the ventilatory effect, the minute ventilation, that's what this is dependent on CE.
Yeah.
What is CE?
It's REMI fentanyl concentration in the effect site associated with 50% of maximum effect.
No, that's
Oh, that's
this one.
Oh, darn.
But CE is just, it's a calculated value based on a population of, first it would model plasma, and then off of plasma by applying something which they mention in there, which is a KE0, is a fictive compartment that's off to the side that's equilibrating with plasma because your plasma concentration's high and nothing's happening. And then a few minutes later, or a few seconds later, or whatever, your minute ventilation starts. So it doesn't correlate exactly with plasma. It correlates with something that's different than plasma. And you can characterize that time course. You're not sampling brain. You're not sampling carotid body. whatever. It's just whatever gets rid of the difference between the effect and the plasma. So this is based off of plasma levels, and we're plasma. Did they collect blood? No. So they're not only imputing plasma concentrations, they're imputing an effect site. So those are both calculated. And then the EC50, which you just said what it was perfectly.
It's the REMI fentanyl concentration in the effect site associated.
Yeah, so this is kind of a typical Emax model. So the Emax is minimum, which they said would be no ventilation. So this would be 0. That would be your max because it's an inhibitory Emax model, not an Emax model. That's why the negatives. It's pretty simple. And then this is the Emax equation. And then what's gamma? They talk about it. It's not important. If you don't know, I'll just
I don't know.
It's just how steep the curve is. So it's a sigmoid curve, and the higher the gamma, the steeper it gets.
Okay.
And so opiates tend to be pretty steep, as you know, because you'll go along giving it, and people are still in pain, still in pain, still in pain. You give them the next dose, gone. You give some, they're breathing. You give them a little more, they're dead. I mean, just kidding. But it's a steep curve. So it goes from almost no response to like maximum response pretty quick. So you know this one too. So what's this one about?
Yeah.
So this is another one that they applied.
So this kind of relates to the end-tidal CO2. So basically what they saw that when they looked at the raw data that showed that ventilation increased towards the end of the REMI fentanyl infusion. So they wondered how to account for this. And they were thinking, oh, maybe it's CO2 building up due to the opioid effect of the REMI fentanyl. So they said, oh, this may be a stimulatory effect of the accumulated carbon dioxide. So there's a model by Bullion et al., and they modeled the influence of carbon dioxide rising on ventilation, and so that's formula 2.
Who trained Bullion? Schaefer. Some of his so that's why Schaefer says, aha, I know where this is.
Explains a lot.
Yeah, my postdoc did this. So this is nothing but a hyperbolic curve. And so if this weren't a clinical study, and in fact, if you were doing it in a a laboratory or a clinical research center, like the one I was in on sabbatical, they did this kind of thing. What would they do that's a little different? What could you do? Instead of just, in a clinical setting, CO2 is going to build up. And now you got to account for it, because now it's messing up with your main outcome measure, which is minute ventilation. So how are you going to look at sensitivity to opiate if the CO2 is going up? So they built an equation to account for that that's based on somebody else's work. The other way you could do it is there's equipment. It's not that complicated. It sounds complicated, but you can lock in an end-tidal CO2. And it measures it, and there's a servo control that'll feed in CO2 into your circuit, so your CO2 never changes. So you're at same CO2 throughout the entire experiment. It will not build up or go down. So it's
Takes
kind
it
of
out,
cool.
puts it back in. It's
Huh?
like closed loop, takes it out, and
Yes.
puts it back in.
Yeah, yeah. It's kind of slick. But that's a way of getting around this problem. But this is being done in the OR. That's going to be hard. So that's what this is about. And so the next part of the methods, it talks about a covariate analysis.
Yeah.
How is it used in this study? What is a covariate? So it's so bad that he's the only one who showed up with the method. They probably read the method and said, I am not going near this method. So a covariate is something in the population that you want to compare your model results parameters to. So you're analyzing the model with this non-mem, and then you're going to see if, like, weight, does weight change clearance? Does weight change volume of distribution? Does age change it? Does sex change it? So, and you can test it, and there's a statistical test that is applied so that, and you're looking for p less than 0.1 because it's in a model and you got to be a little tougher on the data than if it was just, here's this set of measurements against this model parameter. It's pretty accepted it has to be p01. So that's what they say in there. But the one that they're really interested in, what's their number one covariate? It's the whole reason they're doing the study.
OSA.
Yeah, OSA or no OSA. Very simple. So, and that's the equation that is testing their hypothesis. So, and I'm not going to go into all the stuff, but basically they're looking at the EC50 for each individual and the group as a whole, and whether they have OSA or not. So OSA would be a 1 or so this is the EC50 parameter, which we'll see in a minute. And this is the one for OSA. And if there's OSA, it's a 1. So it would be the parameter times 1, which is 1, plus this OSA thing, plus something we don't know. We're going to estimate it in the modeling. And if there is no OSA, this is 0, so this just becomes 1, which is the control group. So it's really, but you build this, you have to write the darn equation to make it work. So that's why they put it in there. In case you're going to do it next week, there's your equation.
Thank you.
And these numbers on the thetas are arbitrary.
Oh, okay.
You just have to know when you read this that, oh, they're assigning number 2 to CE50. And they're assigning OSA to 5.
Okay.
I mean, it's ridiculous. You could switch them.
As long as you remember what they're for.
You have to write them down somewhere, yeah.
Did they have other thetas for other kind of subgroups that they use, and they just kept churning through?
they
That's
did.
how they-
I think they said they did sex, they did hypopneas, they did whether you desatted at night or not, they did a few other things too, and tested all of those. But this one was the one, that's why they wrote it down, this was the hypothesis, the last sentence, that's it. So, not going to spend a lot on this one, but this is kind of the obligatory one showing who was in your study, that they had 20 controls and 30 OSA patients, and give their ages, and just all their basic characteristics. And what you really want to see is, did they vary on their OSA characteristics? Or did they vary in some egregious way, like these people were all 90 and these people were all 15? You know? So, anybody want to comment on those? Who had results?
Did they run any statistics on these or no?
Yeah, there's no p-values, right?
That's what I was looking for.
They're all not. Did they just say at the bottom or something?
They don't mention
They don't
p-values.
mention it, but like the age looks a little close.
Yeah, I would say,
The
yeah.
weight looks different.
That's all I would say. Like I didn't notice the statistics here.
This wasn't a cohort matched kind of study. These were just all comers, so it is what it is. But I think on some of these, like the index was 87. Wait, what's that one?
Sleep efficiency.
Oh. Yeah.
But their AHIs are different.
It's hard to read from here. They don't line up. Oh, yeah, so the hypopnea index average was 38. They went down to 24. And these went up to 12. So they had some people with almost moderate. Not too many. And then they go, graphically, they show kind of the two important things here, where you have this DSATs, saturations up here in blue. So that would be this group. And as you move into the more severe sleep apnea patients, there's more DSATs in their sleep. And this is just at baseline. And then this is their apnea-hypopnea index, and they go up to almost 100. And yeah, nice to see that. No, I'm sorry. It goes up to 125. Holy crap. Yeah. See, I'm kind of in the middle. But this is also at sea level. This was at Stanford, so I imagine this blue curve wouldn't be so blue. Or they would be blue, maybe. Yeah. So this is, so who, anybody here have results and want to talk about them?
I had results.
Yeah, so what do you think of this slide?
So this is 4 different graphs. So A is looking at the minute ventilation, and on the x-axis is time, y-axis is minute. And they start at -3, which is before they're exposed to remifentanil, and then at 0 is when they start their Remi infusion. And it's looking at the people in red, which are OSA, the OSA people, and then the blue is control.
So the concentrations head up to 4. Mm-hmm. Are you surprised it goes to 4?
No. Well, I don't know.
That was predetermined.
Right.
It's in their model. They simulated that. They almost have to go to 4. And there's a little bit of difference in the simulation because the age and the weights were a little different. So the simulations, the model accounts for weight because that was a covariate when they made the model. So they're reflecting that covariate here as if it's real. Okay. And then this would be the minute ventilation drop-off.
Right.
And there's, what are all these lines? And what's the name for that kind of a plot. They'll ask, actually the reviewers will ask you for one if you don't supply it. It's called a spaghetti plot. Anybody think of why it's called a spaghetti? I'm just kidding. We used to call, our group would call them hairball plots because they're really, but it basically shows you where most of the data is because you can see where it clusters, it's denser. It also, if you make them two colors, you can see by eye, does this ventilation curve, are there more, are the blues and the reds kind of distributed? And they kind of are. Yeah. So it's not, so the model kind of fits the gestalt of the spaghetti plot for all of these things. But this one is the most important, I think. This one shows that the CO2 kind of goes up, and then this one shows that this kind of plateaus off even though the remifentanil's going up. So again, these are standard in PK/PD analysis. There are these spaghetti plots of everything you measured. So here are the parameters, the results, the parameters they measured. Want to say anything about that? It's kind of interesting.
So it's basically the other charts in sort of like their numerical data, I guess, the way I interpreted it. So you have minute ventilation at the top.
This is baseline, 0.
Yeah.
So at 0. And does that make sense?
Yeah.
That kind of tells you that their mask wasn't too leaky.
Yeah.
Because you'd expect that to be in the 6s somewhere, wouldn't you?
Yeah. All right, I'm gonna look at yours because you got it better.
So that's not bad. If it was a crappy, it'd be low. It'd be like 4, right?
And then
Leaking.
Yeah, and then the next one's that calculated effect site concentration.
And then they set the minimum to 0.
Right.
You have to have that in the model or it won't run. You're not going to estimate it because you didn't really push the concentrations high enough to get to 0. So you don't, they just assume you give enough of this stuff, they're going to stop breathing.
Right.
And the other thing that's a little interesting if you're a kineticist is why don't they have this omega squared term for all of them? Well, this one, you know, they said it. So it can't have, so what is omega? So omega is, so you have, the model's going to say, okay, this is your value at the beginning, but each individual gets their own, and that's the spread. That's how much spread there was in the baseline. So that's pretty big. It's like more than 50%. It's big. And then the CE50 is very small. It's kind of surprising. And actually, if you read the editorial, we dive into this pretty deeply, and that's not believable. And it has to do with using simulated data. And the poor man's way of measuring minute ventilation with a camera. And Eric Olafson's an expert on this, and he basically said it's a 1 minute rolling average. So all of the values are correlated with each other. So you can remove, if you remove the correlation, and there's something called a Kalman filter. It's a horrible equation. I've never used it, but Eric, who's an engineer, said, oh yeah, it makes you can make uncorrelated measurements, decorrelate them, but they didn't do it. And he said that's the main reason that was so tight. But anyway, and then what's a bootstrap? So what they do to prove that their modeling was good, just to say that there wasn't any bias or some screw up in the thing, what you do is you reanalyze. So you take your 50 patients, you take 2 out, and you randomly take 2 out and you randomly duplicate 2. So the program does that for you. And then it reanalyzes the model. That's 1. And then it picks 2 more at random and replaces them with 2 others at random and redoes it. And it does that 1,000 times. It takes days for this to run on a computer. And they got the same basic results. So it's just a way of answering the question, how badly did you screw up? And then these are the types of, this is individual variability, the kind of measurement error as you go along. And those are just estimates, and they're kind of small too, kind of unbelievably. But anyway. Tom, why don't you take this one since you talked about the equation?
Yeah.
There's your equation, equation 2. The hyperbolic, the effect.
Yeah.
And that gets applied to the minute ventilation. Oh, they're just showing that none of this really shows any difference between the 2 groups.
Gotcha.
This one we're going to skip because it's the only thing that was interesting to me on this one is that as remifentanil goes up, minute ventilation didn't change, and it was kind of screwball. Why is that? And why does their model do that? And again, if you do it differently, again, read the editorial. You can make that can go. That should not be there, and it should be. It should. It's an indication that they had a bias in their analysis, slight one. It's not that important. This one we're going to skip. I want to get. This one is anyway. This one's really cool to me because I do kinetics, but I'm not going to bore you with unless you guys want to stick around and I'll talk you through it. So for discussion, let's just jump to that picture if I can find it.
Hold up. So probably that one.
Ooh.
So this made the cover of last month's anesthesiology. And the statement is adults with OSA do not have increased sensitivity to opioid-induced ventilatory depression. That?
Does that capture the study?
That's what they're saying, I guess.
It's pretty strong wording.
Yeah.
It's a broad claim, too.
Yeah.
When? Which patients? Which adult patients?
Meeting the exclusion criteria.
Exactly, not obese.
Awake ones.
Awake ones, yeah. Who've received how much?
No pre-medication.
No pre-medication.
No obesity.
No obesity, no pre-medication. Before or after, they've operated on their adenoids and shit. I'm sorry, stop. As after, it's before they did anything to their airway.
Without measuring anything.
Yeah.
Without blood. I mean, other than the.
So that's not all adults. This is, so I'm trying to say this is why getting these skills is important, because if you pick this up and you went into the OR and you said, hey,
Going to give you a bunch of fentanyl.
I don't have to worry about this. I don't have to worry about this in OSA patients. But yeah, so what do you think? Does this add anything?
It made me think about like when you have a patient with OSA, and at Denver Health, one of the attendings really likes to use remifentanil for max, and that's like the closest like clinical correlate of like an awake patient who just gets a little bit of opioid, and they do it in patients with OSA, and it's been okay. So that like made me think, okay, maybe it's reasonable.
But I think this study, there was one in '09, there's one about to be published, and I think they're all saying the same thing. There's probably not a receptor or drive mechanism within your brain that's different, just straight OSA patients. There could be a lot of other things, obesity, et cetera. But this is starting to look like it's not a pure sensitivity issue. Might be. This is just one study. There are other ways of doing it, but that's a strong statement. And the conclusion, if you read just the abstract, would be almost as strong. Although, to be fair to the authors, I'm not being fair maybe to these guys who put that on the cover, but hopefully it was just to get you to read the article, not to go start treating patients. But it says, our results may not apply to other obstructive sleep apnea populations, to patients in other clinical settings, and even to our study participants when sedated or asleep. Because of the arousal state dependency of the central ventilatory control, especially in OSA, and so this is full of caveats. But it would have been very interesting if the CE50s were different. And they were a little different, but they were in the wrong direction.
Look at the byline too. It says trusted evidence, discovery to practice. Right, so you need to be careful with your wording that it's not misinterpreted.
And the reason I put this up here today is that the editor-in-chief there's been a letter written by 4 folks, one of which is Frances Chung. Anybody remember? She's the one who raised the alarm bells and really showed that OSA is a big problem in respiratory complications. So she's a co-author, and so is the president of the American Anesthesiology Patient Safety Foundation, Mark Warner, saying that they felt that this on the cover, the statement was maybe, he said there's a lot of skeptics out there who don't believe any of this stuff, and this is going to be their ammo, and they're afraid this could do harm. So they want to know if since I wrote that editorial, did I want to weigh in? I said no. I gave them some tips on how to answer it, but and part of the reason, one of the other people who wrote about it, who's done probably, I told you I was at a place that did respiratory depression work. My co-author is from Leiden, and his boss is a co-author on the letter complaining about the cover. So that's another reason I didn't want to drag him in, start an argument with his boss. That would not be good. But, any questions about any of this?
Why did they pick remifentanil? Is it because it's hard to measure, so that they felt more comfortable using like a model like this, and then they felt like that would hold its water? You know what I mean? I'm just wondering, because you could give people like another opioid, do the same thing.
There's probably 2 reasons. One is, anybody have a opinion? Well, one is this was pre-induction, and what was their stop criteria? Did you notice that?
I don't remember.
How many?
Apnea.
Like 10 seconds at sub 85?
Sub 85 or
Observed apnea?
for 60 seconds. So you could turn it off. They could pull, and they'll be back.
Yeah.
So it's less dangerous. That's one. And they were maybe a little worried about taking these people in the OR and not having an airway and just ramping up this infusion of Remi. The other is that the model's pretty good. So it's, even though it's criticized for not measuring blood levels, if you had to pick one where the variability is not as big a problem as probably a REMI. But I think it was more the safety. And the rapidity of getting to a high level.
Yeah.
Take longer, less predictable.
Yeah, you could get up there pretty quick.
And onset's pretty good
Yeah.
with remifentanil, pretty fast.
Gotcha.
Yep. And the other piece that's missing from this, that if you were doing a real PK/PD study, you turn off the infusion and you continue to measure minute ventilation. And they had to start the case.
Yeah.
So back to that point you said, these are some of the things that you can do or cannot do in a clinical versus a controlled setting. So it's a convenient sample, right? They had people already coming for this surgery. So it's a very relevant patient population, but you give up some of that control, like having the washout period, doing a crossover, trying different opioids, controlling things.
They see it too.
Right, but they're much more expensive too, right? You probably have to pay your participants, you need a dedicated research center.
Do you think these guys did a lot of work on this study? It's a rhetorical question. I think they did a lot of work on this study. To get maybe a questionable answer, it's kind of like, wow.
Probably mostly in the analysis, though. If you think about what the actual clinical data collection looked like, they recruited patients, enrolled them, brought them back to the OR, put a camcorder up, tightened their mask too tight, and then that's it, right? That's most of the heavy lifting's on the analysis end of things.
So another little inside dope. Hope I'm not talking out of school too much, but Steve Schaefer did all of these graphs, all of this analysis, did not help design this study, and was not happy when he got this set of data to analyze. So I wasn't part of the review process, but I got the reviews so I could write the editorial. Everything they asked him to do, like that CO2, he did. He just said, fine. I'll do whatever the reviewers ask. He didn't argue. He just kept answering their questions, and you saw, I don't know if you noticed, but there's a supplement, and it's full.
Even with the caveats, they're getting angry letters. So
Yeah. So anyway, I just thought you'd get a kick out of that. Oh, hopefully the next time you see a bold statement on a journal cover, you'll, especially if it's something you know about, which is anesthesia. You can judge this.
Did Dr. Henhorn write anything on this article?
Well, I figured with something like this, I kind of know the backstory, and we could get it. So this isn't the only example where this happens, but this was one I could talk about, and we haven't done a drug one yet, really despite me really wanting to do one.
So it's important, if it seems complicated, to just come back to the basics of what you need to know. What's the hypothesis? What did they do? How did they do it? Even if you don't know the details of the math or the model, you can still evaluate it looking at those basic criteria of any study. And that's the point of this series, is that you have a set of tools that you can apply to any of the literature, so you can stay skeptical but stay informed and up to date to know what's known and what's not.
Okay,
All right.
good.
Thank you.
Thanks.
CA wants to grab something to eat or drink and head next door. Steve Zucker's got the workshop for you. Everybody else, you're free to go.
Huh?
That was a beast.
I know. No, I was like, I quit. Oh my God, this is statistics.